Thank you. Thank you, Dr. Parker. It's a hard act to follow. I'm not very musical, so let's go ahead and get started. This is essentially case-based. Is the microphone okay? Am I too loud? Okay. So this is essentially case-based, and what I want to do, I'll probably skip a couple of the cases because I know we're about 10 minutes over time already. So what I wanted to do was really, the big message I want to send to primary care physicians is that we're a team. And based on ASCO and the Institute of Medicine, I think the biggest message is that we need to work together to take care of these patients, both acutely when they're going through treatment, as well as chronically after, for our long-term survivors. So essentially, let's just get right into the cases. Okay, so the first case, and this is a little bit of my personal bend. When I'm sitting in a big group, I like to kind of think through things and look at a case, and it kind of clues me in. So the first case, this is a 64-year-old woman with stage 2 breast cancer diagnosed 6 years ago. She was treated with adjuvant chemotherapy. What's TC? That's Taxol and cyclophosphamide or Cytoxan for rheumatologists as well in the room, and radiation followed by hormonal therapy. So you note that her platelet count has been decreasing slowly to 73,000, not anything startling, and her hemoglobin has decreased to 9.4 over the years from normal. She's macrocytic, but just slightly, and this has decreased over the last 3 years. At that time, it was normal. So the most likely cause is this is normal. This is chemotherapy and chemotherapy-related myelotoxicity. She may have developed an enlarged spleen from all this therapy. She has treatment-induced myelodysplastic syndrome. This is a secondary lymphoma from her treatment. Or the breast cancer has returned, and now she has metastatic breast cancer to the bone marrow. And I wrote these questions, and these probably wouldn't get through to a board question because I just wanted people to kind of think about it. So what is this? And this is treatment-related myelodysplastic syndrome. So one of the, and I think, Dr. Parker, these drugs probably date back to when you were treating as well. So a lot of these drugs are 30, 40, 50 years old. But the alkylators and the topoisomerase inhibitors, the biggest category of topoisomerase II inhibitors are the anthracyclines, doxorubicin, daunorubicin, as I have there. So these are the two big offenders for treatment-related myelodysplastic syndromes. And I think the couple of clues I wanted to show you in the case is that these are typically very, very slightly macrocytic anemias, and then the platelet count is usually down a little bit. And you can see a little bit of leukopenia as well. What are the alkylators? So there's a list of a few alkylators, cyclophosphamide or Cytoxan. The platinums too. I think those are the two big ones. The platinums aren't classically alkylators, but they are alkylating agents. The topoisomerase inhibitors, or topoisomerase II inhibitors, as I said, these are mostly the anthracyclines like doxorubicin or adriamycin, as in AC, that you may see adjuvantly in breast cancer. So what is the workup? So for this lady who's 64, she's not transfusion dependent, or at least I didn't tell you she was transfusion dependent. Does she need a bone marrow biopsy? I think back in the days we used to just look at peripheral smears, but a peripheral smear and a reticulocyte count is probably enough to look for the hypolobulated neutrophils that you may see, or funny-looking neutrophils or funny-looking white blood cells, and as well to get a reticulocyte count to really look at the health of the bone marrow. A bone marrow biopsy, on her, I think we could argue back and forth whether we should do it and make the diagnosis or not, because if she's not treatment dependent or transfusion dependent at this point, do we need to do that? As I said, the alkylators usually have this latency of about 5 to 10 years. So some of you may be seeing these patients 5 to 10 years out from, especially breast cancer, which is, as I showed in that first slide, the biggest group of survivors as far as women go. What is the difference between MDS and AML? Things have changed a lot since 2008. So if you haven't looked at a lot of hematology since then, the only difference between AML and MDS is the percent blast in the marrow. It's 20%. We used to have this transformation category for 20 to 30%, but that's the only difference. So AML, obviously, we would treat much more aggressively. The other thing I want to point out is that for these treatment-related MDS and AMLs, these are very aggressive. These are very difficult to treat. So the second case, This is a 68-year-old woman. This is what I treat. I'm a GI oncologist at the Huntsman. She finished adjuvant treatment with FOLFOX 2 years ago for stage 3 colon cancer. She complains of numbness and pain in her toes, which began typically about 4 months into FOLFOX treatment, which we do for 6 months. She sees you for management of her depression and hypertension. An exam of her lower extremities is normal motor, and I guess there's a neurology kind of component to this, so this is my neurology contribution for the day. Exam of is normal, and the most likely cause of her neuropathy is 5-FU, which is a 60-year-old drug, treatment-related diabetes, B12 deficiency from terminal ileum resection, oxaliplatin, or closet alcoholism. And again, I wrote these questions, and this is, they might not be the greatest questions, but I want you guys to kind of think, what would I be thinking if I saw this patient in the clinic? And this is oxaliplatin. So what is FOLFOX? It is an acronym. The FOL part is the folinic acid, the F part is the fluorouracil, the 5-FU, and the OX is the oxaliplatin. Oxaliplatin has been in clinical use for about 15 years. And by far, to me, sometimes it's a little, I guess it's a little sobering that still what I use in my clinic and what does most of the work is a 60-year-old drug and 5-FU. But oxaliplatin causes by far the most toxicity when we're giving adjuvant FOLFOX. So up to 90% of patients will develop some sort of neuropathy. The grade 3, the grade 4, the ones that are very, very difficult, people can't button their shirts, people can't do their typical ADLs because of the neuropathy, that's much lower. That's probably in the 10 to 20% range. And we try, as oncologists, we try to drop the drug before that happens. Hand symptoms typically reverse by 18 months. They can also get kind of oropharyngeal symptoms as well, but that's usually acute and that goes away. Foot symptoms, however, may persist. And I'll tell you, there's no great preventative measures, and if you look at the NCCN guidelines and if you look at a lot of the data, we've tried giving calcium and magnesium prior to the infusion because we think at least one type of the neuropathy may be related to those cations. So there's really no great preventative measures. Here's a list of the drugs that can cause it. I just want to point out platinums are one, or the antimicrotubules are another group. So the taxanes and the vinca alkaloids like vincristine, those are really the two big groups of medications that cause neuropathy. And as you can see, really oxaliplatin is one of the worst. In my experience, it's much worse than even cisplatin. So what is the treatment? We've tried antidepressants and anticonvulsants first line. But I'll tell you, a lot of times this neuropathy is not painful. It's just a sensory neuropathy. And in my experience, these have not helped at all. The gabapentins, the SNRIs, and the tricyclics, I've tried them, and I have not had a lot of success. Topical agents I've tried as well, lidocaine and capsaicin. And as my own personal pitch, we have a wellness center right next to my clinic, and we have acupuncture there. I've actually had quite a bit of success with acupuncture, and the Huntsman currently is undergoing a study with acupuncture, especially for neuropathy. There are small studies in the 20 to 30 patient range that have shown benefit. So don't forget about integrative approaches. I think that this is an important kind of, throwback, now. But remember to look at the whole patient and to think broadly. And I think acupuncture is actually a great adjunct and much less toxicity than gabapentin. So the third case, this is a 46-year-old woman with Hodgkin's lymphoma diagnosed 15 years ago. And we can say she was a stage 3B. She now presents with a painless lump in her neck. And on exam, you notice you notice two anterior cervical chain lymph nodes, 4 centimeters, mobile, non-painful, non-tender, no overlying skin changes. And let's say her breast exam is unremarkable. What should be the next step? So Hodgkin's lymphoma 15 years later, and she presents with very obvious, I always think of anything above 2 centimeters on the short axis as being pathologic on exam. So CT scan of the chest, abdomen, and pelvis. Go right to a biopsy. We think this is malignant. Just send her back to her hematologist, breast MRI, or FNA the mass. And when I looked at this, I thought, well, which one would I do? I would start with CT scans, but the point is, you have a patient with Hodgkin's lymphoma. I think you guys are going to be taking care of a lot of these patients as well. Hopefully the hematologist will still follow along, but sometimes after 5 or 10 years, they kind of drop off the radar from the hematologist. So CT scans of the chest, abdomen, and pelvis try to figure out what's going on. Really the pitch here is with Hodgkin's lymphoma, and with a lot of malignancies, like CLL patients, I've seen, I for some reason have quite a few patients with secondary GI malignancies from CLL or from hematologic disorders. So I think secondary malignancies is an important piece, and I think this is where we do well as oncologists and hematologists. I think where we don't do as well as you guys is treatment of even acute issues like hypertension, diabetes, and doing a lot of the actually healthcare maintenance and screening as well, which I think is very important in this patient population. So this is just a quick slide to show you that breast cancer in this series, I think this was published in 2002 in Blood, but this is Hodgkin's lymphoma. You can see non-Hodgkin's lymphoma, which actually far increases your risk for non-Hodgkin's lymphoma, which we see much more commonly as a second malignancy in these patients with Hodgkin's lymphoma. But breast and lung are very common. Remember that a lot of these patients, especially 30 years ago, were getting mantle field radiation, so a huge radiation field, which puts the breast and the lung at risk. Case 4. So this is a 64-year-old woman in your clinic who had stage 2 breast cancer 6 years ago, treated with adjuvant chemotherapy and radiation. Similar cases as the first case. Now she presents with dyspnea on exertion and cough, and you hear rolls at the bases on exam. The most likely culprit is radiation-induced pericarditis. I think we heard a little bit about atrial fibrillation earlier. Is this new onset atrial fibrillation? Is this vasospasm resulting in an MI? Did she get IPF from chemotherapy? Or is this anthracycline-induced dilated cardiomyopathy? And this is, at least I tried to write the case as an anthracycline-induced heart failure. So this is a cumulative dose effect. Most patients, this is not an idiosyncratic reaction. So this isn't somebody that shows up and either gets it or doesn't. Usually there's a cumulative dose, so we as oncologists and hematologists pay a lot of attention to the cumulative dose, especially of doxorubicin or adriamycin. It does usually present within 1 year, but it can be as far as 10 years out. So if you see a patient with heart failure and you remember, wow, she had breast cancer a few years ago, 5, 10, 15 years ago, remember that this can be anthracycline-induced heart failure. I think this is something we all learn in medical school and probably still have somewhere in the back of our mind, so I try to bring it back to the forefront. The mechanism for anthracycline-induced heart failure is actually fairly poorly understood. So we used to think it was somehow mediated by reactive oxygen species, and that was mediated through iron. So in children, especially young children with ALL or with sarcoma that get a lot of anthracycline, one thing they'll try to do is use chelators prior to giving the anthracycline, and we think that there is actually plenty of data to show that can attenuate the heart failure. But again, we used to think it was mediated through these reactive oxygen species. The newer data suggests that it's through that topoisomerase. Again, that's the unwinder of the DNA. And it's probably mediated through topoisomerase beta in the cardiomyocytes. Generally, this heart failure is not reversible. But just again, to go back to what are we good at as oncologists or hematologists, the treatment of heart failure really will largely be in the hands of the cardiologists and the primary care physicians. So this is treated like any other systolic, usually systolic, with some diastolic heart failure. So this is the last case. This is a 64-year-old man with metastatic colon cancer, no other significant medical problems, and he's currently undergoing therapy. He presents to the ER with a headache and a blood pressure of 220 over 112. The most likely culprit here of his out-of-control blood pressure and probably concomitant headache from the out-of-control blood pressure is A, he probably has an underlying pheochromocytoma, which is extraordinarily rare. I think I've seen 2 since I've been a fellow. Hyperthyroidism, maybe it's related to therapy. So I haven't told you what therapy they're on, and I think this is where I think we get quite a few calls at the Huntsman, and I did as a fellow, where they say, what is this drug? And I can tell you, I sometimes say, what is this drug? I mean, there are so many, I think in 1993 or 1994, I think there were 17 FDA-approved anti-neoplastic drugs. Now there's well over 100 or 200, and they're accumulating quickly. So it's rising exponentially. So there are drugs that I don't even know. But I think the point that I'm trying to give you here is, and we'll talk about this on the next slide, is to give you a basic idea of classes of drugs. So does he have a pheochromocytoma? Is this hyperthyroidism? Did he somehow, I told you oxaliplatin can be neurotoxic. Does he have autonomic instability from oxaliplatin? Never seen it. Just kind of made it up. Avastin or bevacizumab, that's the brand name and the generic name. This is bevacizumab-induced hypertension. Or he just walked into the ER and has white coat hypertension now. So this is bevacizumab. And here, I think one thing I want to convey is some of the traditional chemotherapies, those toxicities, we're very good at figuring out. But at the Huntsman, we have a large phase 1, phase 2 program. So a lot of the newer drugs, we don't even know all the toxicities. We're still learning about them. I mean, we may have, I saw a patient on one of these small molecule inhibitors, which I'll talk about in just a moment, who had horrible hypothyroidism from it, and we hadn't seen it on trial yet. So we were 30 patients in, I think, to trial, and she presented with hypothyroidism, and I'm sure it's from the drug. So bevacizumab, see if this pointer works. Okay. So when we look at the end of the name, if you guys are trying to figure out what a drug is and say, I wonder what this drug is, and you look and you find the generic name, anytime it ends in mab, that's a monoclonal antibody. If you look at the 2 letters right before that, that'll tell you whether it's humanized or whether it's chimeric. Like cetuximab, the XI, will be chimeric. So not that you need to know this, but if you guys want to figure out what some of these drugs are and what the toxicity may be, mab is a monoclonal antibody. So the monoclonal antibodies, they shouldn't have a lot of off-target effects. So they should be very specific for their target. So any effect we'll see should be an on-target effect. The CI here is circulatory system. So this is an anti-vascular drug. So bevacizumab is a monoclonal antibody against VEGF. And what is VEGF? Vascular endothelial growth factor. So this is how tumors, this is at least part of how tumors undergo angiogenesis and bring in a new blood supply. So the way that I usually explain this to patients is, this is a drug I'm going to give you to cut the blood supply off to the tumor. That's a far oversimplification. What it probably does is normalize blood flow to the tumor so that chemotherapy can be delivered better. So we don't, in my world, I never give this as a single agent. There's only 2 kinds of tumors. That's brain tumors and ovarian tumors where we'll give this as a single agent. But this is a very common drug in practice. So bevacizumab, and I'm not paid by the drug company, by the way. So bevacizumab, anti-vascular drug. Okay? So if we see hypertension from bevacizumab, that's what we call an on-target effect. We're hitting the target in the tumor, the VEGF, and this is actually VEGF that's released into the serum, and we're trying to basically mop it out of the blood. So that's an on-target effect. That's the same VEGF that's going to be causing the hypertension. Okay? If we have something like cetuximab, where these patients get a horrible rash, that's an epithelial growth factor antibody. So that's epithelial growth factor that's in the skin as well. So those are on-target effects. I think with the monoclonal antibodies, the toxicity is easier to know, okay? And it's not as much of a wild card. Now, if you see the NIBs, sunitinib, this is Sutent. So a lot of our renal cell carcinoma patients, I think a lot of these patients are turning into 5, 10-year survivors. Okay? So you may be seeing some of these patients that are on Sutent, posapunib, sorafenib, Afinitor. This is more for hepatocellular carcinoma, but this can be in renal cell carcinoma. So you may be seeing long-term survivors or people that are living with cancer on these small molecule inhibitors. Now, a small molecule inhibitor, its target is a tyrosine kinase. And if you remember back to medical school, and some of you may be more adept with this, but if you remember back to medical school, what does a tyrosine kinase do? A tyrosine kinase, what it does is it takes a downstream target that I'm going to signal to tell the cell to do something. Sometimes it's tell the cell to grow and proliferate. And what I'll do is I'll take ATP, and ATP is really the energy currency of a cell. So I'll take ATP in, and I'll use that energy and that phosphate. That's what a kinase does. Remember, it phosphorylates, and I'll phosphorylate something downstream. Now, a lot of our tumors, what happens is you have aberrant tyrosine kinases. The classic is like CML. So Gleevec, which has been, again, in clinical practice for 15 years, in about 1999 or 2000, Gleevec or imatinib, again, imatinib, inib, that's a small molecule inhibitor. Now, what happens is the drugs are designed to fit in that ATP binding pocket. So if I have an ATP binding pocket, like in CML for BCR-ABL, it's not like a monoclonal antibody where I can say, okay, I'm going to zero in like a smart bomb on my target. It's much less targeted than that. So even though we call this targeted therapy, in real physiology, we usually hit probably 5 to 10 different targets. So here we're going to see a lot more toxicity, and that's the point I want to make. So for those of you that want to know, I wonder what the doctor's treating here, this patient's on this unknown drug, if it's a pill, it most likely will be a small molecule inhibitor. Most of these monoclonal antibodies are given by IV infusion. In fact, all of them are. Okay? So here, if we see a rash, the rash is not an on-target effect. And most of these small molecule inhibitors are actually targeting these tyrosine kinase receptors. So VEGF receptor, or the vascular growth factor receptor, are actually tyrosine kinases. But we can't just target that VEGF-R1 or R2. We're going to have a lot of off-target effects. So even though, part of the talk, actually Dr. Sharma was going to give this talk, and part of the talk is in the future, can we get more targeted and less toxic? I don't know if that's true, to be real frank with you. I mean, maybe it's not quite as toxic, but a lot of the toxicities of classic chemotherapy, where we're just disrupting DNA repair and replication, a lot of those toxicities are very predictable. If we have hair loss, it's because of the follicle that's actively dividing. If we have mucositis or mouth sores or diarrhea, that's because the mucosa is rapidly dividing. That's predictable. I think with these small molecule inhibitors, even though we like to think, these are much less toxic, and it's true for a majority of patients. It is much less toxic. They don't lose their hair. They don't get very sick. But some of the toxicities can be harder to predict. And this is where I think you have to, I still like to think of myself as an internist, and you have to really keep your internist hat on. And this is where I think we can work together. So, conclusion. The newer agents, are we developing safer drugs? I think the toxicities are a little less known. With a lot of the classic chemotherapies, again, that's why I brought up the anthracyclines. That's something that's very predictable. It's a cumulative effect. And the neuropathy, those are very predictable. A lot of that neuropathy is happening along the axon where the microtubules are shuttling different nutrients down the nerve. And that's actually that same microtubule for the spindle of DNA, that's the same target. That's why we see a lot of neuropathy with those antimicrotubules. Those are predictable toxicities. Those are things that are usually also cumulative effect, that if we take off the drug, it can improve somewhat. And the neuropathy is still, there's nothing magic that we do that you guys don't do, probably better than us for treatment of that neuropathy. I think the biggest thing I can tell you, this is the number of the huntsman. And you can always, I think one thing we don't get enough of, and we're on 24 hours a day. We have fellows that are on at night. But if you guys ever have a question, you say, this is a weird thing. I wonder if this is coming from this drug. Call us. If you call the main number, they should be able to page us and get in touch with the oncologist within 3 or 4 minutes. You can call the transfer center if you want a patient sent there. But if you call this main number, somebody will always answer. You'll get a human being. You won't have to hit a lot of buttons, which drives me crazy. I usually just hit 0 or pound until I can talk to somebody. Sometimes it doesn't work. But call us. Really call us. Again, shared care.
Can a patient call that number? It's only for a physician.
Patients can call that number as well. Anybody can call that number. And you can always just say, you know what, even if you don't know who the treatment doctor is, say, I want the doctor that treats lung cancer. And I talked to Dr. Akerley yesterday, and he said, yeah, tell them, call us. So we're not, I think there's always this thing, and patients, I'm sure you guys see this as well, where patients will say, oh, you're so busy, I don't want to bother you. But that's what we do, right? I mean, we're not too busy, especially for patients and patient care. So that's what we do. Shared care, I think, is the most important thing I can tell you guys. We're not very good, as much as you think we're good at screening for other cancers, we're not very good at that, and the data has bore that out. So again, ASCO, the American Society of Clinical Oncology, and the Institute of Medicine, they really do, they suggest that we all work together and have a shared care model, okay? And then that's it. I'll end there and try to stay on time. Thank you very much for having me, by the way. Questions?
Yeah. I have a friend, and she's undergoing cancer chemotherapy, and she's had an intercurrent PE and lots of infections. And she never knew whether to go to her local cancer doctor here, who was affiliated with the Huntsman Center, or she should go to her primary care doctor. And that created kind of a little conflict for her, not wanting to insult or not knowing who to ask. So when someone has intercurrent infections on chemo, who is the best person, their oncologist or their primary care doctor who they know to treat?
Yeah, that's a great question. I trained in oncology at the University of Utah, and I think it's a very unique place. I'm sure all of you guys came from all over, really the Northwest and maybe even farther. And I think each situation is very different. There are times where I say, you know what, don't drive down from Montana, don't drive 8 hours if you have a UTI, and come see me. And I think as long as we know about the infection, that's it. I do think there's a lot of treatment that we do locally. So I think the model should be case by case. If somebody's in Salt Lake City 2 miles from us, I would rather have them come up and see me so I know what the infection is, I'm involved, and I know what's going on. But I talk to a lot of primary care physicians because of the unique, I think, geographic layout that we have where we share care, and I'm fine treating their infection there. And this is probably more in oncology than hematology. I think hematologists, especially for infections, would like to be, they would like to have them there because you can see some other unique infections for people that are immunocompromised for so long and so profoundly. But for me, I think it's fine as long as there's good communication to be treated locally. PEs, somebody was talking about warfarin versus one of the new DTIs. And I actually use a lot of Xarelto, rivaroxaban, just because it's simple. We don't have to monitor it. And I actually think that I've had less bleeding complications than I have with the warfarin. So for PEs, I truly do think that can be managed locally. The one caveat is people with active cancer, there's data to show that Lovenox is better than warfarin. So that is just one caveat. And as long as you give a phone call to the oncologist, I think it's fine to be treated locally.
Dr. Gilchrist?
Yeah.
We have presentations on cancer therapy, survival rates, cures, and so forth, but we hear very little about the collateral damage, and I'm very happy that you talked about this subject. My wife had breast cancer treatment 5 years ago, and Taxol was one of the energizing bunnies they used. And she's had a great deal of trouble with neuropathy. We're still dealing with it. We've tried everything but witchcraft, including your needle points. And she's also getting platelet issues now. So I'm glad that you addressed this topic, and hopefully we can be more mindful of that.
Thank you very much.
Is there any possibility of, if we see these patients from treatment, we get summaries of their treatments, but we very rarely get any information about potential side effects of the treatment. So yeah. I would think that one of the things that could be done to help us would be to, when we receive reports of the patients had the treatment, of a summary of watch for these problems associated with the treatments, because they not only maybe not see me in the office, but they may see my PA or my nurse practitioner in the office, and their level of knowledge about the side effects of the chemotherapy is even less than ours. So I would think that'd be something in the shared care model that would be really, really helpful, even if it's a standard printout of this is the agent that was used, these are the potential side effects that the patient may encounter.
Yeah, you're almost like somebody I paid to ask me this question, because it was one thing I didn't bring up here. So one thing we're trying to develop, I think that's an excellent question. You know, if you read the package insert for Tylenol, I don't think anybody in here would take Tylenol. So if you just give somebody something, print them out something from the internet, you can just have this huge host of things of look out for these 1 million things. But I think that's too much. So one thing we're trying to do, you know, one thing I do with every single patient, I have a piece of paper that I actually still handwrite what my recommendations are, what the medication changes are. I try to be very clear about the follow-up plan. But one thing we're trying to develop is a treatment summary for patients. This is what you've undergone, and here are just a few bulleted things to watch out for. Not to be afraid of and walk around like you have a gun at your head, but this is something that you should know. You know, if like I said, if the patient, your blood counts start having a problem, remember that this can be a problem from chemotherapy, and this needs to be addressed further. So we are working on that. I'm working on one of the ones for colon cancer survivors. Dr. Anna Beck at the Huntsman, she's working on one for breast cancer survivors. And the hope is that we can get one piece of paper that says, this is a summary, especially for our adjuvant treatment patients, this is a summary of what you've undergone, and this is this is what you should be looking out for. All right. Well, thank you very much, and enjoy the rest of your conference.
A couple really quick announcements. One is we found a key up here. If anyone's missing a key, it was here up front. Second is we'll have to exit from here as quick as possible. They need to clean up for lunch. And our next lecture is in the ballroom over in, well, 15 minutes. Is this your key? Okay, we found it. And the next segment for 2 hours is actually the residents' presentations, which when we review critique of the conference is actually one of the most popular segments of the conference. So I hope you enjoy it. That will be starting in 15 minutes. Thanks.